Hello, and thank you for joining us for this webcast on the critical role brokers and employers play in fighting the obesity epidemic. This program is part of the SHRM webcast series. You can learn about upcoming and on-demand events from our e-newsletters and the webcast homepage at shrm.org/webcast. SHRM thanks the Diabetes Leadership Council for sponsoring this program and our series of free webcasts for the HR community. About today's program, health experts have declared an obesity public health crisis. This webcast will explore how employers and those who guide them can take a proactive role in combating obesity and, in turn, lowering long-term health costs. Our panel moderator today is George Huntley. He is a founding member of the Diabetes Leadership Council and currently serves as CEO of both the council and its affiliate, the Diabetes Patient Advocacy Coalition. Mr. Huntley has been living with type 1 diabetes since 1983. He's also the COO and CFO of Theoris Group. In his corporate role, Mr. Huntley has been a plan administrator of a self-insured health plan for more than 20 years. With introductions complete, I'm pleased to turn over the webcast microphone to our speaker, George Huntley.
Thank you, Mike. And good afternoon, everybody. I appreciate your spending your hour with us, and delighted to get into this topic, which is very important for all employers and this society. We'll start with some very quick disclosures. This program is sponsored by Eli Lilly and Company. Speakers will receive an honorarium, and our medical experts provide their expertise to Lilly on occasion. The Diabetes Leadership Council is an organization. They're comprised of former leaders of national diabetes organizations. We're parents, we're patients, we're allies. We're a policy shop that are there to educate legislators, advocates, and through this program, employers on issues important to the health of people with diabetes. Now, today's program is dealing with the primary driver of type 2 diabetes, which is obesity. Obesity is a societal problem, and we are going to talk about the state of obesity, the complex chronic disease that is obesity, and the stigma and the bias and discrimination that often comes with overweight and obesity. And we're going to talk about the employer's role specifically in dealing with this public health crisis. So I am pleased to now invite Dr. Allison Sexton Ward to join me here to talk about the state of obesity. Dr. Ward is a research scientist at the University of Southern California Schaefer Center for Health Policy and Economics. She is an economist with extensive experience on healthcare policy and pharmaceuticals, and she is a co-author on a paper released this spring called Benefits of Medicare Coverage for Weight Loss Drugs, which is important to the conversation today, and we'll talk about. So welcome, Dr. Ward. I appreciate you joining us today. Now, we are losing I think you may be muted. So, okay, very good.
Yeah,
we are losing this fight against obesity. You and your colleagues have studied the obesity issue. What is the current trajectory? How bad are we doing?
Yep. Things don't look that great. And really, despite decades of public health efforts to fight obesity, we can't seem to reverse the trends. In fact, we're outpacing projections. Each time we put out new projections, we outpace them. And so currently, survey data shows us that we're right about at the point where the average BMI in the United States is 30, which is really right at that threshold for categorization into obesity. And so we're climbing ever closer to 50% of Americans with obesity.
So it's depressing to hear that. And I mentioned earlier that it's a public health crisis, and I know you agree with that assessment. So can you share a little bit more on the scope of the problem?
Yeah, I think everybody's sort of heard about these increasing obesity rates, but maybe the more salient conversation is around the dire health consequences of obesity. And obesity is actually second only to cigarette smoking in terms of leading cause for preventable death in the U.S. And nearly 1 in 5 African Americans and Caucasians nearly 1 in 5 deaths among African Americans and Caucasians between 40 and 85 is attributable to obesity. So those are scary statistics. And I think the truth is clear that what we're doing right now is failing to slow the trends. And part of this is a lack of coverage for the available treatments, and particularly pharmaceutical treatment therapies. Uptake rates remain exceptionally low because of the coverage and are at roughly 3%. I think as we economists think through the problem, we want to think about its impact largely on society, which would, on the next slide, George, yeah. I think we think about this increased, the death is associated with increased mortality. That's actually shaving years off people's lives, decades for some people if you reach obesity at a young age. And that increased mortality is really because of the association between obesity and so many chronic conditions that are that stem from disability and pain, but really obesity is associated with increased diabetes, heart disease, hypertension, cancer, stroke, and many other conditions. And what those health conditions do is tax the economy. So we get increased healthcare costs, obviously, from these increased chronic conditions. And right now the estimates are at an excess of $260 billion annually related to obesity, or 50% higher annual medical costs for an obese patient compared to their non-obese counterparts. And less studied and discussed are the productivity costs that are probably pretty relevant for the audience today. And so that's both increased absenteeism, that's days missed from work, but also what we call presenteeism, which is less productive time while at work. So that's incredibly hard to measure, but still a huge cost related to obesity.
Yeah, and I think you talk about as a plan administrator, a self-insured plan, you've got a patient or a participant that costs 50% average on average more than the rest of the population. That's got to start getting some attention as we go through this. So I appreciate you bringing that up. So obesity rates are growing really faster, but in the workforce, since this is all workforce, what does this look like today?
Yeah, I think that's where we see the highest average BMIs in that working age population. And as you see on the graph in front of you, for folks 35 to 65, your average BMI is all above 30. And I think younger populations also, we're just seeing younger Americans earlier and earlier reaching obesity. And it's natural as we age and we sort of hit that retirement age that we start to lose weight. So it's really thinking about treatment. It needs to come in this working age population where it will have the most impact.
Yeah, and I think that's a number. And as we look at our employee base, most of those numbers are over the average of the technical diagnosis of obesity. So we really do need to be looking at this. It's the employers that have this population. So let's talk about the minority communities. I understand the trending of hitting them harder than the non-Hispanic white community.
Yeah, I think that's probably something that most people would believe is true, but the numbers are kind of stunning. And so we used nationally representative survey data and see that in 2023, the obesity rate for the Black Americans is at 60%. It's at 51% for Hispanics and 41% for whites. So I think that difference is striking. And that's the obesity BMI 30 or greater. That's the second set of bars on the graph here. And as you look to the right, you see the breakdown of different categories of obesity. And what's even more telling is that difference is really driven by the highest categories of BMI. So Black and Hispanics outpace the white population, especially within the 35 to 40 BMI category and 40 plus, which is where we get the highest association with those chronic conditions.
Yeah, and again, it's telling, and you get some of our employers in the South and some of the what we used to call the diabetes belt are going to be facing this even more than some other geographies. So you sufficiently depressed us. So give us a little bit of good news. I know that you looked at the study of this on the benefits of Medicare covering. What would happen if Medicare covered these anti-obesity drugs?
Yeah, so at Schaefer Center, we have a nationally representative microsimulation model that we can use to look at huge health interventions like changing coverage policy for obesity weight loss drugs. And so we look specifically at what would happen if Medicare started covering weight loss drugs, and what if Medicare and private insurance started having broad access or broad coverage for weight loss drugs. What would happen after 10 years or 20 years when compared to the status quo, the current coverage rates? And we show, especially here relevant to the conversation today, those bars in purple, which is Medicare and private, that we would see huge reductions in these chronic conditions, and particularly diabetes. After 20 years of broad coverage, we could see the rate of diabetes fall by 17%. And to put that into perspective, that would be 20 years from now, in 2043, that would mean 23 million fewer people with diabetes, or over the course of the next 20 years, that would be 45 million fewer person years, or years lived with diabetes, because of broad treatment. And I know we're short on time, but to tie back into that sort of disparities thing, we know from past research that there's a lot of social and economic determinants of health that lead to that disparity that we see. But what is less well known is that those same determinants impact how people respond to treatments. And so the current standard of care, which would be intense behavioral therapy, the Black and Hispanic population are less likely to be successful on that type of a therapy. But we know and have shown in research that as you simplify treatment, we make it more accessible and we eliminate some of those disparities. So the disparities we see in these chronic conditions would also decrease dramatically.
Well, and I think, if anything, this slide depicts the role that an employer has to play in addressing this, because it's only when you get to the purple where the employers, the private insurance, in addition to Medicare, because the people, as we shown in the earlier slide, they're during their working years, they're already living with obesity. The earlier you address it, the longer term benefits there are. And as a patient and as an advocate for someone with diabetes and the diabetes community, reducing the number of people with diabetes by 20 million and is a huge dream of people with diabetes. So thank you so much for sharing this information. I think it's fascinating. I really appreciate your perspective today. And I will continue this dialogue as we go. And I'm going to now move to a poll question for the audience. And do you know the percentage of your employees with obesity? Now, we're undoubtedly tracking the number of people on our plans with diabetes, because we know that diabetes is a major cost driver of our health plans. But are we even tracking it for obesity? And so hopefully that's up on your screen. I'd urge you, do you know if you're tracking it? Yes, no. If you're not sure, say you're not sure. But I would appreciate, just give us a sense of if it's something on your radar. I think we're kind of early in the dialogue on obesity. We've got a lot of work to be done on this topic. So I'm going to now move this forward to see where people are. I really appreciate your participation in this. So we've got just under 15% said yes, 62% said no, we don't track this, and 23% weren't sure, which is understandable. But it does, what gets measured gets managed. I'm a CFO. I've been in manufacturing. I've been in professional services. We all know if what gets measured gets managed. If we're not measuring this and tracking our cost on it, we can't hope to manage it. So step one is at least get a baseline of where you are. So hopefully this will wake us up a little bit. So now I'd like to invite Dr. Miller and Dr. Campos to join me on a medical panel. We're going to talk a little bit about the disease of obesity. Dr. Eden Miller is an osteopathic board-certified family practitioner. She is certified in obesity management, and she is the CEO of Diabetes and Obesity Care, LLC in Bend, Oregon. Dr. Carlos Campos is a clinical adjunct professor for the Department of Family Medicine at the University of Texas Health Science Center and has been practicing primary care medicine in New Braunfels, Texas since 1984. Thank you both for joining us today. I really appreciate your partnership in this, in helping to get this information out. So I'm going to start here. The slide says obesity is a disease, but it's a relatively new designation. So Dr. Campos, let me start with you. Share with us why this designation is so important and some of the drivers that make this so challenging to address.
Well, thank you, George, for having us, because it's incredible still to I think me and Dr. Miller to think that many physicians or many clinicians don't think that diabetes is a disease. They consider it more of a willpower problem. They consider this as more of a blame kind of issue. And, we go around the country talking about, saying, no, the American Medical Association, the World Health Organization say, no, this is a disease, just like diabetes would be, just like high blood pressure would be, hypertension, hyperlipidemia, high cholesterol, that sort of stuff. That is a disease. So that's the first thing we need to do, is talk about how this is really a disease, and we should be treated like a disease. It's a chronic disease. And as we go on, we'll talk about all the other diseases associated with it. So it's vastly underrated. You'll be surprised how many clinicians, when we look at the chart, don't even have that BMI on there or what their waist circumference are on there. But there's a lot of multifactorial drivers. I was looking at some of the questions. I had heard about the Bible Belt, but I never heard of the fried chicken belt. And one of the questions there. But because, there's certainly all these environmental things that we were talking about earlier, about fructose and all these other foods that we have that make us desire to eat more and more. But one of the things that I wanted to really just spend just 1 minute on is that we're looking at this obesity as a disease, and there's certain things that we have to understand the biology of it. And one of the biologies is this: it's got you can see it's got metabolic adaptation and set point. One of the things that we know, in about 90% of people, the body always tries to defend the set point. And what's the set point? That's the highest weight gain that people get. And so, it's like anything else. The body tries to survive, and it tries to defend that. That's why it's so hard for people to lose weight. I tell people there is really this hormonal conspiracy for you not to lose weight. Your body's always trying to go back to that highest weight gain. It thinks that's a normal weight. And we always know those people that have lost 50 pounds over 5 years, and they say, you know what, I can do it with diet and exercise. That's usually maybe less than 10% of the population. Most people, the body defends that set point and wants to go back. And that's why the second time, through this concept of metabolic adaptation, it's harder to do it the second time. We as clinicians, we really have a lot of empathy for people who are trying to lose weight. I know Dr. Miller has the same thing with the patients come in. They'll say, I'm eating nothing but lettuce, and I'm still cannot lose weight. It's because the body's trying to defend that set point. And so we're trying to move. If we can go on to the next slide.
Yeah, I'm going to show you that. Yeah,
we're trying to move and really shift from this whole blame issue of saying, this is really a willpower issue. This as saying, and we're trying to move from blame to biology. Said there's a biology here where the body is constantly trying to defend that set point and going back to that. And that's why not only is diet and exercise important, and diet and increased physical activity, but also some of these medicines that we have that have made phenomenal, that have been phenomenal and been game changers for us. Now, we had several questions about body mass. How do we diagnose diabetes? Right now, we use the BMI, and it's not perfect. I have some bodybuilders who have BMIs of 31, 32. They should be considered obese, and they're not. I mean, they got a lot of muscle mass. But, overall, this is what we have right now. I think if you look at the literature, the ideal way is to probably go to a waist-hip circumference. But, let me just say this. Most clinicians in this country don't even put waist circumference in their medical records at all. So right now, the best thing we have, and there's been some suggestion where we should move from this, But right now, the best thing was have this body mass index, which really compares your weight with your height. And we're seeing that if you're 30 or above, then you're in the obese category. You can see the different classes there.
And if you look at the public health arena of this is getting and capturing the largeness of the problem, pun intended, as we go on there. So Dr. Miller, let me bring you into this discussion as we get into this. You know, in the diabetes world, which we're both in, the costs and all of the horrible things that eventually kill you or come from the complications of diabetes, and the list of obesity is worse. So share with us a little bit about this.
Yeah, I call it metastatic obesity. You know, one of the things we can do, look at all those different things that are associated with being above your ideal weight. You know, those are comorbidities. We call those additional things that really shorten our lifespan, make our life, you know, harder to live. But if you impact the core defect being excess adiposity, you know, that's kind of that new term they're throwing around besides BMI. We will determine how people have excess adiposity. There's many ways to do it, but you impact that, you're going to impact all of those other things. So imagine by doing a singularity of a disease, look at all the other diseases you're impacting. You could actually go to an individual who's having a mood disorder and improve their mood, but not improve one of their core defects. And so with all types of chronic diseases, we want to look at the core. We want to look at the central. And I would even agree with you, George, as where you and I live and work, and so does Carlos in the field of diabetes. You really don't intervene with diabetes as a sugar issue. You intervene with diabetes as a metabolic issue. If you intervene with diabetes as a metabolic issue, if we go back to that dysfunctional metabolism, you're going to improve it. So I really think this is one of the core pillars of diseases here in the United States. We've got to start recognizing it as such.
And, you know, and it's clear that it just gets worse as you get through that continuum, that trajectory of obesity, class 1, class 2, class 3, everything gets worse. So we want to treat it earlier. So let's touch a little bit on the good news of the treatment. It's possible. So give us you know, there's a lot, as we think about, do I need to lose 50 pounds in order to make a difference?
I think this is really the hope and opportunity slide. One of the things, as Carlos and I work in the field of dysfunctional metabolism and glycemia, we go out to our peers and we educate them. And we say, hey, when you talk to a person, an individual, about improving their health, how much weight do you think they need to lose? Man, we hear numbers like 50 pounds, 100 pounds. And sometimes that's just not motivating, right? It's just a buzzkill. But what the real concept is we look at it in three kind of different targets. You know, a weight reduction of 5% is a meaningful impact. It's a very, very good start. Some would suggest 3 to 5%. It's that conversation you have with the individual. It's obtainable. Everybody listening right now who's not at their ideal weight, can you lose 5% body weight? You all say, yeah, I can totally do that. That can make that impact. And we look at how it improves all of those metrics that are surrounding the dysfunctional metabolic individual. Now let's move to the 10%. So the diabetes prevention program says 7%. My husband is presenting at the ADA this year about a new reclassification of prediabetes, and he is talking about how exponentially improvement with a 10% body weight reduction, even continuing to go up to 15%. Now you're impacting and preventing a chronic disease that has a very large price tag with it. When you get up to 15%, which is what I call the holy grail, I deal this with in stages. I often have to go beyond lifestyle. I'm always about lifestyle as a foundation, but understand, even if those individuals who are listening who have high cholesterol, can you just do it on diet and exercise? No. You're trying to overcome a genetic predisposition, an epigenetic phenomenon of how these genes are expressed. And in order to get to those levels, those ideal levels, where you've significantly impacted your joints, your comorbidities, 15%. So you talk to this about the patients, you make this calculation to them so they feel that it's an achievable type of goal.
Yeah, and I think, you know, I don't need to get back to my high school weight in order to make a big difference.
Exactly.
And exactly. That was really good because I've lost all those. I don't want to look like I did in high school. I just
you'd look pretty weird. You'd look pretty weird, George. We're adults. We're not high school students. And I can't tell you how many times, you know, George and I, you know, or Carlos and I get that, right? How much do you want to weigh? What's your goal? I would like to look like I did in high school. you wouldn't look so good. Your friends would think you're dying of cancer. And no, I don't make it like that. This is here to set an expectation, achievable goal, and to have that science behind you for what you're doing for disease prevention.
And, so we know, and Dr. Campos, I'm going to let you go back to the bad news, right? To Dr. Miller gets the good news here. You're going to get the bad news. The bad news is that that people aren't getting the treatment that they need. And that's a medical issue. That's a thing you were talking earlier about. They're not even capturing waist circumference and hip circumference and things like that. What's going on behind this phenomenon?
And I think part of this, you can see the slide, it says vastly undertreated. And part of the issue, I think, even amongst the clinicians in this country, but also even with the employers, they do not see obesity as a chronic disease. And when you don't see it as a chronic disease, guess what? You're not going to treat it. You're not going to address it. And as you can see here, look at those numbers. Only 40% of adults with obesity or overweight receive counseling. Only 55% have received the diagnosis of obesity. Dr. Miller and I, we have them in all our charts, whether or not, we're both raised as primary care family doctors. So we see people as hypertension, hyperlipidemia, diabetes, and we put the BMI in there because we need to address that. At some point, we have to say, can we talk about your weight? Because the other slide the previous slide that I like, the one that Eden was going through, is that we're in the risk business in primary care. Our job is to lower the risk of bad things happening to people. And as you can see, if you can get up to 15% or higher, you're going to reduce the risk of all-cause mortalities. So only 20% of patients with obesity, even have a contact with clinician. What we do know is that when the clinician actually asks the question, can we talk about your weight? Can we develop a strategy? That 90+% of people are going to address that.
Yeah, and that's the key. It's everybody in America, employers, this audience, doctors, patients, plan participants, your employees, the public, understanding that this is a health issue. This is a public health crisis, and getting away from blame as we go through this. So let's start with the treatments. About people not getting treated, but let's walk through the various treatment options that exist. And the first one is starting with lifestyle management. So Dr. Camps talked. It's not easy. It's hard. Why is it so hard? And what does this really mean? What does this really entail?
Well, I was referring that to one of the questions about the fried chicken belt here in the United States, and what can we do about that? Often I'm also a certified diabetes educator, and I had a diabetes education program here in our area. And I would walk in, I'd say, what do you guys want to, why are you here at this meeting? And they said, we want to know what we're not supposed to eat. And I said, well, then you're in the wrong place. I said, because you can eat whatever you want to eat. It's just, we're going to be talking about portion control. And so, when we tell patients like that, they can't eat certain things, just like your children, when you tell them they can't do anything, they're going to want to do it. They're more apt to try to do that. But no matter what we do, we know that the foundation of therapy has to be some form of diet and some form of increased physical activity. Often in the obesity world, George, we don't use the E word. You know what the E word is? Exercise. We said, what can you do to increase your physical activity? Those are the sort of things that we need to talk about and try to make it as easy. And it's hard to do that when somebody has a tremendous craving for certain kind of foods. And that's the biology of it. Their body's trying to go back to that set point, their maximum weight, that their body thinks that it's a normal for them, and their body's trying to survive. And that's the biology that we have to fight with. And so,
yeah, I'm sorry to interrupt. If you think about as employers, as the folks listening to this, and we get down to, the patient, our employees, they need help on this. They need nutritional counseling. They need intensive behavioral therapy, which many times isn't covered. But our employers will cover smoking cessation classes as many times as that you want them to take it. You can go to smoking classes all day long because we understand how bad that is for the person, the patient, and for the health plan, because those are the most expensive people. But we won't cover nutritional counseling.
Exactly. And that's important. But look at the end of that slide, the bottom of this slide. 97% of dieters regain everything they lost or more within 3 years. Why is that? It's the biology aspect of it. And so that's where we need the help from the employers to say, we have these tools that we can use to help this hormonal conspiracy of saying we got to go back to that weight. And even though the diet and the increased physical activity is important, even though the behavioral therapy is important, we need some tools to affect this hormonal conspiracy to get back to that weight. And that's what we see that's why people regain that weight again.
So let's move on to that. So Dr. Miller, talk to us a little bit about the tools that are out there, the anti-obesity medications, when lifestyle alone's not. I know, and touch on it, because I think you've got to do both. You've got to do all of these things in order to be super successful.
You know, Carlos and I do so much similar things. You know, the way I present it is, you know, your lovely, healthy body has this combination to it's safe, and it's got these 5 numbers, and you could do all the numbers of lifestyle and timing of eating, yet you don't have that number that unlocks that metabolism, that genetic, that hormonal conspiracy. Your beautiful safe still doesn't open. And that's why they get frustrated. They'll say, I'm doing all these things, and how come I'm not losing weight? It's because you've got to address all of them. And so we have those obesity-related medications. We traditionally say they're covered for a BMI of 27 or above with comorbidities. And so we really want to have that foundation of lifestyle management, because it's about being healthy. It's about doing it for the rest of your life. We're not interested in a quick fix. We're interested in a new way of living. And so there are currently 5 approved medications. Many of the new players in the arena are the incretins, neuroendocrine hormones that go against that biology. There are going to be more that are coming. Several have already been submitted. You know, he and I are waiting for some of the new ones to be coming out. These GLP-1s are those super innovators. They're the ones that intervene in such a way where some of the published data is 10 to 15%. It's huge. We call it the non-surgical gastric bypass, right? Because you can't take how many ever million people and give them bariatric surgery. But there is that layering of that medication and intervention. And one of the things that I just always cringe when I talk to Carlos is he lives in an area where he has a higher coverage than I do. I live in Oregon. I got less than 1%. And so for me, accessibility of these agents are literally nil to none, where I have no ability to use them. And so patients are forced to go into a cash pay system. And that's hard. And so Carlos, where he's at geographically, just, you know, got the lottery with it and has much better coverage with it. So it is a limiting factor and a barrier for us as clinicians and interventionalists.
I know there's a question in the on here that why are they? Do they work? And I think you're resoundingly yes, they do. Why are they not covered? And just very briefly, one of the reasons they're not covered is in Medicare, when the Part D law went into place back in 2006. There were no really effective anti-obesity medications. They had speed effectively. That was the only thing out there. So Congress wrote into the Medicare Part D law that it cannot be used to cover weight loss drugs. And you know, fast forward from 2006 to 2023, now we have some real effective drugs on the marketplace, and we've got a legal barrier to getting them covered in Medicare. That's not necessarily a barrier for commercial insurance, but commercial insurance so very often follows Medicare that we do have a natural propensity for them not to get covered right now. So I urge everybody to be looking at those when you're looking at your plans.
George, can I answer a question real quick? The question is, if we use a medicine, the question is, do GLP-1s really need to be taken for the rest of their life? Remember, this is a hormonal conspiracy, as I mentioned, to try to get back to that weight, and your body's always working for that. These medicines work to block some of these channels so that you won't gain weight again. What we do know is that as soon as you stop that medication, that weight comes back. Now, right now, we don't know how to, and there's a lot of research in obesity medicine of how do we reset that thermostat, if you will. We don't know how to do that right now. So until we find out how, we're going to have to continue using those medicines. Yes, they're phenomenal medication. In Dr. Miller and I's world, we call them game changers for us. They prevent diabetes. They prevent a variety of other things. And as all the diseases we've talked about, if we can get up to some 15, even up to 20% weight loss with some of these medicines. So it's an exciting time to be. It's just a matter of us having the access of those medications.
Yeah, and understanding from an ROI perspective, and more studies still need to come out on these. But you saw earlier, Dr. Ward's commentary show, you know, how much reduction in the incidence rates of diabetes and heart disease, et cetera. There will come a savings in health plans for that, and just improvement of life and extension of life. But let's talk a bit about the next the treatment of last resort in this, the bariatric surgery. Pretty invasive, pretty costly, but it has some pretty great outcomes. Share a little bit about that.
It does work. You're fundamentally changing the architecture of the absorption of food. But what's interesting is many of my, our participants here don't realize when you have bariatric surgery, you're actually affecting that hormonal axis. The reason it works is because you're rewiring the digestive system. You're almost, how shall I say, activating that neural hormone incretin response. It's not just a malabsorptive state. Of course, the holy grail is to get decreased appetite, decreased absorption, increased physical activity. Bariatric surgery, if you have complications of a disease, comorbidity, it's 35 and above BMI or 40 without that, we do see a significant impact. I'm not going to deny that a bariatric intervention, especially the sleeve gastrectomy, which is where a lot of the data is coming from. We're going away from the banding. The Roux-en-Y is not as necessary now, but do understand it's a very high price tag. You have to go through a series of approvals, 6 months of approval where you fail weight loss intervention at a high level, psychiatric evaluation, being able to stick with a lifestyle plan. Then you got to meet with the bariatrician. Then you got to get your insurance coverage. And how many people do we have that's struggling with this? 50% of the population, not a good long-term solution. It's there for some who have that intense hormonal conspiracy, and we're glad that we have it. I did see in the chat about how expensive, intervention of obesity is, where we don't know the data. I would disagree with that, and Carlos knows we do know the data. These drugs were obesity. These drugs were diabetes-related drugs that were probably metabolic drugs. I know you guys capture them as obesity-related or diabetes drugs. They're not really. They're dysmetabolic drugs that affect obesity, affect glucose. They have massive cardiovascular risk reduction, massive reduction in conversion to type 2 diabetes. Yes, they're expensive because they're expensive to make, but when you invest on a monthly basis with your employers, you're going to save billions in 10 and 20 years. So we either pay now to help prevent, or we're going to pay massively later in comorbidities.
We've got a lot of things to face here as a country, as a nation, as we go, and we are out of time. But I really do appreciate both of your time and your expertise and sharing. It's so helpful, and thank you so very, very, very much. As we go on, I'm going to move the conversation to a poll question to see, from a plan design, does your plan cover anti-obesity drugs? Are you covering these today? And so it's a yes, no, not sure. I give you an easy multiple choice, but just getting, again, back to this as a benchmark. Are people covering this today? If you would spend a second and, click through, I would really appreciate seeing some people's response. And again, as I mentioned, Medicare Part D law, when it got put in place, it forbade the federal government to doing it. So it speaks to how culturally we are treating this as the patient's fault. People don't deserve access to this. This is because this is a failure. And it's not a failure. This is a metabolic genetic disease state that we're dealing with. I'm going to see what the answers are. Thank you so much for your for participation. Not surprisingly, only 10% are covering it today. 50% know they're not covering it, and 39% aren't really sure. So that's not a surprise in 2023. I would hope as we do this in 2024 and 25 with more updates on what's going on medically, et cetera, and as we think about where things are from a coverage perspective, employers might thinking about expanding that access. All right, I'm going to shift our dialogue here and invite Dr. Rebecca Pearl to join the dialogue. Dr. Pearl is an assistant professor in the Department of Clinical and Health Psychology and in Social and Behavioral Sciences at the University of Florida's College of Public Health and Health Professions. She directs the Body Image and Stigma Lab, which conducts research on health and appearance-related stigma. And I thank you so much for being here today. And the audience doesn't realize it, but she's actually coming to us from Spain. So I doubly thank you for taking your evening to join us here. We know that stigma is a powerful thing, and a sizable portion of the country, but hopefully not this audience after this, believe that obesity is the patient's fault. Could you talk to us a little bit about how damaging stigma and bias can be, what it looks like?
Yeah, well, thanks for having me and for giving attention to this important topic. So we know weight bias and stigma is really rampant in our country and around the world. So weight bias is referring to the negative attitudes that people might have toward people based on their weight. And this usually does apply to people with a higher weight. And these negative attitudes are often rooted in common stereotypes or assumptions about internal characteristics just based on a person's weight. And of course, we know that weight tells you nothing about what a person's personality is, what kind of skills or talents they have in the workforce. But people tend to see a person's appearance and their weight and make these negative assumptions about them. And that can lead to stigma and discrimination. So stigma is when people are mistreated, including being denied opportunities, being treated unfairly, socially rejected. And as was, talked about throughout this presentation, a lot of this is wrapped up in blame and the misconception that weight is entirely within an individual's control. And as we heard, there are biological factors, there are environmental and social factors that determine people's body weight. But when people think that weight is entirely a person's choice and within their control, that leads to negative moral judgments and this belief that they're doing something wrong, there's something wrong with them to have led to that weight gain.
Yeah, so not only do we judge others, we're judging ourselves. And it becomes very, very unhealthy. So we've got a lot of work to do, and it can manifest in a number of ways in society. So touch a little bit about that.
Yeah, so we see stigma in all sorts of levels. So at the broadest societal level or structural level, we can think about laws and policies that perpetuate stigma or that don't protect against it. New York City just passed a law a few weeks ago that prohibits weight-based discrimination. And it's one of very few places in the world that has this sort of protection. So it really is entirely legal in most places to even blatantly discriminate against people on the basis of weight. Of course, we've all seen media portrayals, whether it's in news or television or movies that have derogatory characterization of people with a high weight. We see this in interpersonal interactions. This is a huge problem for kids and teenagers, with weight being the leading reason for bullying in school. We see this in discrimination in healthcare settings, in workplace settings, in educational settings. And then, as Georgie mentioned a moment ago, we can also internalize stigma and turn it inward. So when people, especially with a high weight, are aware of this stigma that is so pervasive, it's understandable that they might start to believe it's true and apply those negative stereotypes to themselves, and as a result have lower self-worth because of their weight. And this also can lead to impacts on a daily basis of, every time someone enters a room, being concerned about how other people are going to be thinking about them or how other people might treat them because of their weight.
Yeah, and it's unfortunate, but it's happening too. I think probably everybody on this call probably understands and sees this happen on a daily basis. So we know that psychological stress is real stress with real health consequences. So share with us, how these stigmas can impact overall health.
Yeah, and there's been a lot of research on this, and this isn't specific to weight stigma. We know this is true for lots of different forms of stigma, but there has been research specifically about stigma related to body weight on both the mental and physical health consequences of this. So yes, stigma is stressful. You can imagine someone saying something critical to you, or being discriminated against, being mistreated. That's a stressful experience. And when people are having this on a daily basis, especially even in subtle ways here and there, that can really add up. And when people are under stress, that takes a toll on mental health. That can contribute to depression, anxiety. We know that people who experience or internalize stigma are at greater risk for eating disorders. And it also has physical health implications. So when people are under stress, that has a response on stress hormones in the bodies, which ironically can also increase appetite and lead to weight gain. And that's something that I don't know that a lot of people realize is, at face value, some people might think, well, maybe stigma is needed to motivate people to lose weight, or if people felt too good about their bodies, then they wouldn't be motivated to lose weight. But weight stigma has the opposite effect, that it actually increases stress in a way that causes changes to the body that promote weight gain, and also can contribute to health behaviors that undermine health. So eating in response to stress is a very common coping response for lots of people, as well as avoiding physical activity. If people feel shamed or feel embarrassed, feel like others are judging them, they're going to be less likely to engage in physical activity. And so altogether, those behavioral coping responses, the physiological responses to stress, increase risk for type 2 diabetes, cardiovascular disease, and other chronic diseases that, we're trying to prevent and treat.
So it's got very real life physical manifestations, which again, for this audience as employers and covered insurance coverage, it's costing this behavior, the stigma that we're helping perpetuate is actually costing us money, and it's harming our employees. I hate to take it to money, but a lot of people, that's how they think when you think about what am I covering, these are the untapped ways, the unappreciated ways that this happens. So, this is a group, our audience is HR professionals. Let's get into how this can actually show up in the workplace. Let's talk a little bit about this.
Sure. Yeah. And there have been studies by very smart economists who account for all sorts of other factors that can affect things like wages and unemployment. And they have consistently found weight stigma and weight discrimination. So we know that there's a wage penalty for having obesity. This is especially among women and especially among people with the highest BMIs. People can be unfairly fired or denied promotions or denied employment because of their weight. And we also see this in kind of more subtle ways of just assumptions that people might make about their employees' capabilities or about their performance. Again, not based on any objective metrics, but just making these assumptions by looking at a person.
Yeah, absolutely. And now let's talk a little bit about, you can reduce it. You can work on it. So let's talk through about some tangible steps the HR team can take to reduce weight stigma.
Yes. So there are a lot of simple and concrete strategies that can really go a long way at trying to prevent and reduce stigma and discrimination in the workplace. One thing is just kind of a way of thinking about body weight as a type of diversity. In our diversity trainings and our DEI efforts, body size and shape are often left out of those conversations. But there's diversity of bodies, right? We all have a range of different kinds of bodies. And so thinking about it in that way can make a difference too. And thinking about, sensitivity trainings and, a zero tolerance policy for any kind of weight-based bullying or discrimination. And then there are things like putting into practice some policies for hiring and for promotions that are based on objective criteria to try to prevent those biases from slipping in. People have probably heard all about implicit bias or unconscious bias, that human beings have biases, and whether we want to or not, sometimes those negative assumptions can seep into our decision making. So things like having a policy where you don't have photographs of candidates who are going to be applying for jobs, to try to remove that appearance bias from the hiring process. Those sorts of things can, be very simple, but can really go a long way to try to reduce the impact of bias in the workplace.
Yeah, that's a really good point, and a tactic or a practice that many firms use. Taking a picture or putting that with is not abnormal. Not everybody does it, but it's not abnormal. I want to start and just touch briefly on the very first bullet here. Start with yourself. Understand yourself first. And And from we had conversations a while back on, you're on the airplane, the oxygen mask comes down, put it over yourself first, and then help the child next to you or the other person. Understand your own biases first, and then you can help explain them and work with the rest of your organization to get better. This is a journey. This is going to take probably a generation for us to deal with, both psychologically, socially, as well as medically. So I really appreciate this conversation. Workplace
and wellness. Just to make a point too about, identifying your own biases. We've been bombarded for a long time with the wrong messages, right? We've been bombarded with these messages that it's a lifestyle choice, with these negative portrayals of people with a high weight. So we've all internalized these messages. And so it's, having these biases doesn't make someone a bad person. It means that we're in a society where we've just been constantly exposed to these messages. So having that openness to take a step back and ask yourself, wow, do I make these assumptions, is a really important first step. And I think we're seeing a shift in the culture. And I think there's reason for hope, because we are seeing more of these kinds of conversations, and we still have a ways to go.
Yeah, we certainly do. And I appreciate those comments. So let me just shift this to workplace wellness. These are extremely popular programs among employees and employers, and they help promote a healthier workforce, and they're well intended. Wellness is well intended, but sometimes less well conceived. So, we discussed diet and exercise fails typically without other interventions. Can wellness interventions help and sometimes hurt if your patient's trying to lose weight? Let's chat a little bit about what works and what doesn't.
Yes. So wellness programs can be very tricky, and they can be done in a way that's beneficial, especially if the focus is on behaviors rather than weight itself. Because people can't just snap their fingers and decide to lose weight. They can, try to change their eating habits, try to change their physical activity. And what you don't want to do is incentivize weight loss alone, which can have all sorts of negative consequences. One being, people might then use kind of extreme measures to try to lose weight that we know are not healthy for them and are dangerous, and are also likely not effective or not going to be effective in the long run. That maybe someone loses a lot of weight very quickly, but then is going to be set up to gain it back even quicker. If folks remember that show, The Biggest Loser, there's been lots of research about that show of how harmful that was to the contestants to lose so much weight so quickly in this extreme way and then gain it back. And we also don't want to create an environment that is stigmatizing for people with a high weight where they feel targeted. So, if a weight loss competition is happening, there's public weigh-ins, that's just a lot of heightened attention to weight that could open the door for people feeling like they can make comments about other people's weight, which we know is really problematic for creating an inclusive workplace environment. But if the behaviors are incentivized and it's more of a focus on feeling good, feeling strong, doing good things for your body, then that can be a much more beneficial approach.
And you look at, from an employer's perspective, nutritious food options in the cafeteria and the lunchroom or the coffee area, if you've got these things. So many of us are now working from home. So you can tell your people to go to the grocery store, buy yourself something healthy, which is a joke. But in reality, there's many people who are now in this. Are we even addressing that with our employees who are working remotely and encouraging them from that perspective? Any tips we're providing there? Stairways. I love this. So if you happen to be in a high rise and you're on the 25th floor, making the if your people can walk up the stairs, you probably aren't having this chat, and you're not tuning into this. But if you are in an office environment that's got the second or third floor, those stairs are a little bit of exercise goes a long way. Back to Dr. Miller's conversation about 5% weight loss. Those things, when you talk about doing the stairs 3 or 4 times a day in the office, huge benefit versus sitting stationary at your desk. talking to your people about, the employee of the month. How many of us have an employee of the month and you give them the best parking spot, which is right by the front door? You should put them in the back. Make them walk the whole parking lot. That they're getting an extra walk. That's a benefit. We should be talking to people about that, about getting those extra steps in. And that's the reward, is we're all going to be healthier. There's so many ways that employers, if we really start addressing this, you peel this onion in where is the inherent stigma in everything we're doing communication-wise. What wellness initiatives are we doing? What are we doing with our health plans, our hiring practices? This goes off in so many different directions that I really appreciate, Dr. Pro, your time and sharing your expertise with this, especially from Spain. And it worked out well. I saw you the whole time, and really do appreciate that. And we've got just a minute left in the presentation. I'm going to just take us to, if there's any questions do you think it would be appropriate to offer healthy meal delivery service as a perk? I think so. I think that's a great idea. As spot awards or giveaways or whatever. Anytime you're doing something healthy, it's not a reward for having a behavior. You're helping teach them and reinforce that behavior. I love that idea. And so there are many ways. Hopefully today has been just a beginning of a conversation as we think about the public health crisis that is obesity, and where we need to go as a country, and the role that employers have to play in this, because employers can't hide behind this. So we hope that you've learned something today. I really do appreciate your time. I'm going to invite Mike back from SHRM to close us out with a few things. There should be this slide deck and some other resources available. I urge you to join at the diabetesleadership.org employer solutions area. We've got some things on your health plan design that we'd love to share with you. And again, really appreciate your time and attention today on this really important topic.
Thank you. Our program is coming to a close, but for our audience members, please do stay with us. We have a couple of important announcements. This webcast is sponsored by the Diabetes Leadership Council, DLC. The Diabetes Leadership Council is a patient advocacy organization whose members are individuals with decades of diabetes experience and leadership who work to advance patients-first policies related to diabetes at the local, state, and national levels by engaging policymakers and public and private sector influencers. This program is part of the DLC's efforts to educate employers on health plan design options that lower their plan risk and costs while improving employee health. You can learn more at diabetesleadership.org. Before we sign off, for the information they provided today, we want to thank our panelists, Dr. Rebecca L. Pearl, Dr. Eden Miller, Dr. Carlos Campos, Dr. Allison Sexton Ward, and from the Diabetes Leadership Council, George Huntley. And we want to thank everyone tuning in for being with us and for choosing SHRM for HR webcasts. That concludes this program.